Let's take a look at a pathology of fibrillary astrocytoma. This is, you know this slide, you'll know everything that you need to know about fibrillary astrocytoma. What you want to pay attention to prior was the gross and microscopic features of fibrillary. It's a grade 2 in terms of grading or classification under WHO. Mean age here, look at this, a very young patient, less than 35. Initial management is often observation if symptoms are not serious, and oftentimes you find that with brain tumors. Mean interval to progression, approximately 4 to 5 years, and management after progression is usually surgical resection, radiation, or both. And mean survival after radiation treatment is 6 to 8 years, and this would be found what's on in your blue book. The pathology for anaplastic astrocytoma. This is referred to as being your grade 3 under WHO classification. The mean age here would be 40, still relatively young. Initial management, surgery, and radiation. You get in there, you remove this sucker. Recurrence is almost certain. Anaplastic is absolute chaos. Remember, mitotic rate is incredibly high. Progression to glioblastoma is frequent, unfortunately, and could occur within 2 years. Here, the management, if it's symptomatic, which is going to occur quite quickly, it's called surgical debulking. Steroids for mass effect, and maybe perhaps chemotherapy would be required. Anaplastic astrocytoma. 2 down, under, neuroepithelial tumor. And what are these? These are astrocytomas. Glioblastoma multiforme. You pay attention to this one. This is WHO grade 4. Mean age here would be 60. Necrosis or microvascular proliferation to diagnosis. Remember, we talked about angiogenesis taking place, proliferation of endothelial cells. Initial management, maximum surgical resection. But even then, there's no guarantee. Management after progression, symptomatic, once again, if chemotherapy is required. However, take a look at the survival. Mean survival after initial treatment, 1 to 2 years. So then it comes into risks versus benefits, and whether or not, that ends up becoming a behavioral science type of issue in terms of communication with the family and whether or not they wish to opt for surgery and so on and so forth. Look for those type of scenarios. Here's a histologic picture of glioblastoma multiforme. What I want you to pay attention to is right there in the middle there. And you find a surrounding border of a palisading pattern of glioblastoma multiforme. So of all of the astrocytomas thus far, in an adult, we looked at anaplastic fibrillary, and here's a glioblastoma multiforme. You want to know its histologic picture in great detail. Under astrocytomas, we have one that's left. You'll notice that we talked about grade 2, 3, and 4. Grade 2 was fibrillary, grade 3 was anaplastic, and grade 4 was a glioblastoma multiforme. It came under the category of astrocytomas, and astrocytomas are neuroepithelial tumors, which means that particular tumor is then arising from your brain, the parenchyma. So we have one left. That's grade 1. We leave this separate because pilocytic astrocytoma. The reason that I separate the pylo and cytic because I want you to pay attention to cytic. And by cytic, I want you to think of it as being cystic. So when I say cystic to you, what does that mean? It means that you have a fluid-filled compartment, don't you? So where is this fluid-filled compartment located in this child? Do you realize that the reason that this is kept separate of all the astrocytomas is because this is the one that's most commonly found in children? Now, be careful with this. This pilocytic astrocytoma is the most common astrocytoma to found in a child. And the reason I'm being very technical here is because if there's a question at any point in time that's been posed to you, what is the most common brain tumor overall, primary in a child? Then it would be medulloblastoma, which we haven't discussed yet. Is that clear? Okay, now let's move on. Typically occurs in children located in, where is this cystic type of lesion located? This cytic or cystic type of lesion is located in the cerebellum. So how would your patient then present? Now think about the cerebellum. In a child, what is it going to do? It's growing. What does it look like? It looks like a cystic-like structure. And whenever you think of a cyst and it's fluid-filled, then if you have an imaging, you can only imagine that what you're going to find in the middle of the cyst would be of what characteristic? Would it be opaque or would it be lucent? Fluid appears as being lucent in this case. And so therefore, as it grows, it's going to then impinge upon what? In front of the cerebellum. There you go. So now you're talking about the fourth ventricle. This is not good. If you start then increasing the obstruction of the fourth ventricle, then you're creating obstructive, non-communicating type of hydrocephalus. Keep those things in mind. Usually cystic. So from henceforth, the clinical pearls here would be children, cytic. By cytic, you refer to cystic. Located where? In the cerebellum. Therefore, what kind of presentation? Usually there would be in coordination with walking. In other words, maybe ataxia. A quick little words about some of the remaining astrocytomas. Pleomorphic xanthoastrocytoma, typically once again here seen in children, could be found in young adults as well. Usually located in the temporal lobe. Pleomorphic P as in temporal lobe. Children, perhaps. Young adults. And we have something called Sega. When I was growing up, back in the day, Sega was actually a video game. Nowadays, I don't even know if it exists. But anyhow, we have subepidermal, we have giant cell astrocytoma. And here you're thinking about this being periventricular type of tumor and with what's known as tuberous sclerosis. And of course, tuberous sclerosis being a genetic issue with the particular gene known as TSC. At this juncture, we have now completed our neuroepithelial tumor classification or subtype of astrocytomas. We began by looking at common adult type of astrocytomas, and we have now looked at the most common child astrocytoma, or astrocytoma to be found in a child, Blinger polycytic, looked at pleomorphic and Sega.